But first of all, I'd like to bring in our panelists and start with you, DeAnna. I was sort of looking at your justice leadership website earlier on, and I think earlier on in the pandemic, you were saying that 8 out of 10 of the hotspots for COVID-19 in the United States were actually in prisons and jails, which struck me as really quite astonishing. Now, I think that was in June. So I was wondering if you could maybe sort of is that still the situation in the United States? And this would indicate a major problem with preparedness, sort of that, the prisons weren't prepared for this. Why has that been the case? And maybe why haven't we learned from history?
So one of the things, thank you guys for having me here. One of the things that we identified immediately is because of the congested living areas, the inability to social distance, the fact that hand sanitizer was a contraband that could not be allowed in prisons, created this atmosphere. And then when we talk about the inadequacy of healthcare, we started to see a huge amount of individuals testing positive once individuals started dying of COVID. Mm-hmm. Governors were on the TV across the country talking about locking down their cities, their states, but they never mentioned the prison population. They never talked about the population of people. They talked about nursing homes, they closed down schools, and they didn't even talk about the employees that are state employees who are an essential part of the community. They're individuals who live in the community, and prisons don't close down. So here in Ohio, one of the top prisons has a capacity of 2,500. And by the time they got in there to test, 1,700 inmates tested positive. But there was no solution. There was no inability to social distance. They started utilizing solitary confinement to try to house people differently, but it just became overwhelming. And we really feel when we talk about the history of pandemics, the history of disasters, while this is pandemic across the country, across UK, USA, everywhere, we've had disasters. We have a history of disasters. We've had hurricanes. We had Hurricane Katrina, Hurricane Ike. And when you talk about, let's just talk about Hurricane Katrina that devastated Louisiana. They had emergency preparedness plans for the Humane Society to get cats and dogs out. But the inmate population was taken to bridges in the hopes the water wouldn't rise. Here we are 15 years later. Louisiana still is a spot for hurricanes. Now we have this pandemic, and no processes were even taken into considerations of what do we do when we have an emergency? So Just Leadership, being an organization that focuses on formerly incarcerated, we all were formerly incarcerated. We were founded by an individual who was formerly incarcerated. We started demanding emergency preparedness plans like hospitals, nursing homes, and schools have. Correctional facilities in the US do not have to have emergency preparedness plans that focus on preserving the lives of the individuals in there for accreditation and funding. So we're actually demanding that they have these and actually institute decarceration strategies that preserve the lives of individuals currently incarcerated.
Thanks very much, DeAnna. And I was wondering that this does seem to be a huge problem right across the United States. And you have a very big prison population, don't you, in the United States? I think one of the highest per capita in the OECD. Have there been any states that you think have done particularly well? I mean, are there any state governors maybe who have given a priority to addressing the health needs of people in prison?
So I think one of the things we have to realize is that while there's 2.2 million people inside correctional facilities, there's a difference between jails and prisons in the US. Mm-hmm. And by that, jails are where people are pre-trial, meaning they haven't been found guilty of anything. Mm-hmm. Prison is the sentence once you've been found guilty. Jails have more flexibility of a local sheriff making a decision to say, I'm not going to hold you on cash bail. I'm not going to hold you. Whereas prison officials actually are legislatively bound by either the governor or the state legislation, or the judge who sentenced the person. So the prison official themselves can't make any decision. I call it a daycare center. The parent drops the child off at the daycare center. The daycare center has no right to release that child until the parent comes back or the parent says so, right? So with governors, some governors started to look at who's 90 days to release. But nobody has been aggressive to say all technical violations, which means a person didn't commit a new crime. They were on some type of community supervision and violated a condition, such as they didn't report on time, they failed a drug test. So when it comes to the correctional population, no governor in the United States has been willing to lose the political capital to make an outright decision to override the legislation. So again, that population is just sitting there, which is why we're talking about vaccines, and that population isn't even prioritized to start getting vaccines.
Yeah. No, this is something I want to sort of come on to discuss. And in fact, I've already seen the first question was about this. I was just totally anticipating this, but we'll perhaps come on to that in a moment. Well, thanks very much for the time being, DeAnna.
Hi, yeah, thank you. Good afternoon, everyone. Yeah, I was curious to know, so given what we know and what has been spoken about already about how the coronavirus pandemic has played out in prisons, I was hoping to ask whether inmates should be among the first to receive shots of COVID vaccines.
So one of the things, and I'll start there, when you think about the population, so the priority list from the CDC says that essential workers in healthcare and individuals in nursing home congested care are going to be in what we're calling Group 1A. Group 1B is going to other individuals, and they've breaking this priority down. But what they failed to add is the fact that prison workers are essential workers. Prisons don't close down like hospitals don't. Those are members of the community, and that also individuals who are imprisoned are in congested living areas with the inability to actually social distance. So some people will even push back and say, well, older adults are more vulnerable, but we have older adults in prison as well. We have individuals with comorbidities and other underlying issues in prisons as well. So how do we stop this cycle? Well, one of it is people are actually, our first set of vaccines, we know we have to have 2 shots. And the first set is only enough for about 35 million people, 70 million vaccines coming in. If you have to have 2 shots, the first round is for 35 million people. So how do you start prioritizing that? And we're facing a real big dilemma here. But then also, we're still in vaccine trials. You have 5 companies trying to come up towards a vaccine to be FDA approved, but there's still some clinical trials. And the fear is that they're trying to use individuals in correctional facilities for the clinical trials, but not the access to the vaccine once it's determined. So there again is the dehumanization of the individuals and the lack of the willingness to even compensate them like we do the general public when they do clinical trials. So it kind of goes back to, yes, they should be prioritized for access, but also it goes back to the racial disparities and the fact that our criminal justice system in the US was built on a historical aspect of slavery, and that those individuals are still considered less than human, again, in this aspect, and we're responding in that way as well when we start talking about access to vaccines and who should be utilized as trial participants in that process. You're muted.
Thank you very much, Catherine. And just wondering if sort of panelists have got thoughts about, you know, the provision of palliative care in prisons and its absence. Is this something that you've come across?
I wanted to. Catherine said 2 things that I think is very important for our audience to understand. And I want to start with the felony disenfranchisement. Whereas individuals who are serving time, except for Maine and Vermont, you never lose your right to vote. You don't have a right to vote. But what we found at this time during the census, you can be in a prison, which most US prisons are in rural areas, but the population comes from the urban area. While you can't vote while you're in prison, during the census for political capital and political gain, that rural area gets to count that prison population as their home state. And that is funding attached to each person, but that person will never reside in that rural area for services or resources. They go back to the urban area that didn't get to count them to get that federal funding. So that's huge when you talk about felony disenfranchisement, but they will count you for political gain and finances. Second, when we talk about, community healthcare and correctional healthcare, I think people misrepresent prisons are in some type of community. So if it's supposed to represent what is in the community, it is part of communities. But in the United States, we have a Medicaid exclusion, which is an entitlement program, and there's an inmate exclusion that excludes people who are serving time, which makes the quality of care not have to be equivalent to what we have federally said community health care should be. So it's all these federal rules that justify what Celia talked about, the profiteering of healthcare, the inability. And one of the lessons I learned as the director for county administrators overseeing a local jail, while the correctional healthcare was privatized and taxpayers paid for it, when there was a lawsuit about the medical care, because that profiteering company was representing the county was responsible for that medical healthcare, because this was just a consultant of the county. But the consultant was the one who was mishandled the actual care of the individual. So when you start putting all these together of accountability, we've actually allowed correctional healthcare, one, not to be accountable financially. They'll have some standards of care, levels of care, but when it all is said and done and there's some actually wrongdoing, typically the county or the city, the mayor, ends up paying the family for any wrongful death lawsuits that occur in a jail or anything of that nature. So it's really this real disconnect of what's said on paper that correctional healthcare and community healthcare should match, but in practice, it never plays out that way.
And DeAnna, any thoughts on how to improve accountability?
So one of the things definitely with the premises of what Just Leadership, we believe those closest to the problem are closest to the solution, but furthest from resource and power. So we have built a criminal justice system, a system to address the needs of individuals impacted by the criminal justice system that doesn't include our voices in those conversations. We always try to create a system to say, this is what individuals who've been impacted need. And we simply say, ask us. Invite, do not make decisions about us without us. We don't make decisions around women reproductive rights without women. We don't make decisions around veterans without veterans. We can no longer continue to make decisions around criminal justice and people who've been impacted by the criminal justice without us being at the table. And this is exactly what Just Leadership is. We empower people who have served time, been impacted, to elevate and utilize their voice to say enough is enough. This is what we need. This is what our communities need. Our communities are marginalized and oppressed, and we really created a system that actually keeps people entrenched in that cycle of oppression once they've even served time, which is supposed to be rehabilitative. So my call to everyone on this call is to start having conversations. I call them non-traditional conversations. Sitting down with a person who's been impacted by the system that you traditionally would never sit down with, and we can work with Cecilia and Ash to actually start facilitating some of those. I think this is how we're going to start being aware of what the needs are, because you went directly to the community most impacted to get that information. I want to follow up on that. And I'll follow up on it because I think what has happened is what Just Leadership pushed for. Just Leadership pushed to control the narrative. And at the height of Black Lives Matter, the George Floyd death, defund the police became the words, and we allowed the opposition to control the narrative to define what that means. In New York City, Just Leadership led the campaign to close Rikers Island. But we said close Rikers Island to build communities. It went over like a hitch. Same definition of defunding the police. We're saying when you close Rikers, take that funding and build our communities, invest in our communities around mental health, substance abuse, housing, education. But because it was attached to defund, and the people of privileged communities had more access to media and the narrative, they controlled the narrative. And this was my argument with Black Lives of, when we say something, we have to own it and define it, because if not, the other side will take it to define it, to diminish its worth and its impact. And that is what has happened. So I'm a huge wordsmither. Words mean different things for different people. And if the wrong person get a hold to the definition, that's the definition. So it's not defund the police like Ash says, it's really invest and build in the most marginalized and oppressed communities that have been impacted by over-policing and over-incarceration.